On this X-ray, this CT scan, you can see that the lateral femoral condyles on both sides are missing anteriorly. Reconstructing that is going to be quite difficult, and you need to have a thought process in place before you embark on surgery. So going to the nitty-gritty of this topic as to what are the options to deal with bony defects. You could just do one simple thing, just take more bone off. That would be easy, just cut it to the defect, but for anything, there are repercussions. You could translate the component away from the defect, and finally, under the umbrella of reconstruction, several things could be done. So what happens if you just increase the bony section? If you do that, the strength of the bone diminishes 33% for every 2 centimeters that you go down, and as a matter of rule, you should never resect below the defect unless it just happens to be 5 or 7 millimeters and attacking the normal side takes care of it. And almost certainly, you should never cut below the head of the fibula. The caveat there is, there are some patients in whom the fibula head is quite high preoperatively, and if that is the situation, then it is imperative that you will do that. But you need to be very careful that you don't actually land up way beyond the fibula head. What about translation of component? Doesn't require a lot of preparation, but if you want to put a stem and stuff, then it becomes quite difficult. You should be attempting this unless the defect, peripheral defect, is less than 50% of the involved condyle. Majority of the times it's the medial side and you're translating it laterally. The chances that the stem would abut against the lateral cortex of the tibia is very high. You invariably land up with a smaller tibial component, so you need to be aware what sort of mismatch the system that you're going to use allows. Because if you already have a mismatch between the system, between the component sizes before you decide to translate, you can't really do that. For example, the PFC system and the next-gen system, it allows 1 up, 1 down, and if you land up with a 2 up, it's incompatible. And that compatibility as a surgeon, I think you should be aware of. It affects the force transmission. So if you put in a small tibial component, there is a large amount of force trying to go through a smaller area, and therefore the stresses on that component increase, and therefore the risk of loosening goes up. That's something to be borne in mind before you make a decision, because in contrary to that, there is a better option of trying to reconstruct the bone. Not a difficult option, but it needs further inventory. So what happens with reconstruction? You can simply use bone cement, you can use various types of bone graft, metal wedges, or go for a custom-made implant. All of them will allow you to achieve what you really want to achieve. As far as bone cement is concerned, it's great. You can actually get it to conform the shape of the defect, but beware, it's not going to unite to the bone, neither is it going to incorporate with the bone. It's of limited durability, and eventually it will fail, even if you put it with screws. It's a glue, it's not a glue, it's a grout. It's just a surface for the implant to rest on, and eventually that will give way. You could cement with reinforcement, whether you use screws or a mesh, and you can see what has been done here. Several screw heads have been put to try and incorporate the cement. This is purely a temporary, and I put it to you, this is an emergency procedure because the surgeon hasn't thought about it. He's got caught out and he has to get out of trouble. I would not advocate this, although I'm aware that particularly in India, several people have got good results out of this, but I haven't seen any long-term papers to support the use of this, and I would struggle in my practice to do that. So what are the other options for reconstruction? We could simply use autograft bone, which is optimum biologic material. It's osteoinductive, but it's limited in availability, and therefore when you cut your bone, make the bone cuts, you need to be fairly careful. And my rule in my operating theatre is that you save the bone till the very end, till I ask them to get rid of it. The nurse is not allowed to do anything to it. Allograft is similar to host bone. Potential of osteoinduction, disease transmission is an issue. If you've got freeze-dried bone or a heavily irradiated bone, then there are some structural issues with it. There are advantages and disadvantages with any procedure. With bone grafts, the advantage is that you can avoid custom implants and therefore the cost associated with it. You prevent cement fragmentation, preserve subchondral bone, and you can maintain a uniform cement thickness provided you've got the bone graft level right. The disadvantage, local bone may be limited, which I've already alluded to. Fitting may be a bit difficult and a bit fiddly to try and cut the bone around to actually accept the stem and the prosthesis. And incorporation is completely unpredictable. Although, if you've prepared the bone well, if you make sure that there is no cement in between the bone graft and the host bone, it should not be a problem. If you compare cement versus bone graft, cement is easy, structurally but structurally unsound. You can fill up contained defects, but there's a high failure rate. As opposed to bone graft, particularly autografts, fixation with screws is achievable, but you need to think about where the screws should be. It shouldn't land up that you put the screws and then when it comes to placing the tibial component, the screws are in the way. The defect needs to be more than 50%, it may be peripheral or contained, and you should get a cement column more than 5 millimeters. But this is the bit I like the best, probably as an orthopedic surgeon who likes to play with toys, the modular and custom components to try and rebuild the bone. It gives you a better platform, it's easily available, certainly in the West, and the restoration of joint line is much more easier. So let me summarize all this and go back to specifics. The femoral bone, because that's what we're talking about, the femur and the tibia. Femoral bone defects are less common in primary total knee arthroplasty. The defects are usually contained. The peripheral defects and revision and inflammatory arthropathy. And the idea is to preserve the bone, reconstruct it, and share the load at the interface. What is important, this bone loss may be symmetrical or asymmetrical. It may be central at times, although very rare, more common in the revision scenario. And also in the revision scenario, you need to think about the median and lateral peg holes, the distal ice cream cone, and the asymmetric ice cream cone. This is one that I'd shown you before, where you can see, if you analyze it, the entire lateral femoral condyle is missing. And incidentally, this is bilateral. And I put the CT scans up there for you. The lateral femoral, the anterior compartment, the lateral half is missing. There is no system presently which actually reconstructs the anterior bone loss, and I had to think on my feet as to how I was going to do that. Unfortunately, I managed to use the cut bone, fixed it with the screw right at the edge in a position where I could place the implant. And you can see the severe patellofemoral wear. The patella is just a sliver of bone, and fortunately, she's doing reasonably well. The femur defects can be reconstructed using bone graft, stems and wedges, mobile bearings, and presently sleeves. Sleeves is a fantastic addition to the armamentarium available. It is relatively rare to use it in the primary setting, but certainly very common to be used in the revision setting, particularly converting a revision from a total to a revision knee. In contrast, the tibial bone loss is much more proximal. It's usually asymmetrical. You can get a full slope of bone loss or an ice cream cone, or you may land up getting an asymmetrical ice cream cone, which often is quite difficult to deal with. Although the present generation of sleeves does allow it, but you lose more bone in the preparation of these asymmetrical cones. And if the defect is contained, it's probably one of the best situations. The tibia is more at risk at the femur. Please do not cut to the defect. Please spend time to analyze your cut. Cut less, you can cut again. Once you've cut it, you cannot put it back again. The surface weakens the subchondral bone, and you need at least 5 millimeters of medial or 8 millimeters of lateral subchondral bone, otherwise your fixation is compromised. And when you have the exposed cancellous bone, you often need to protect it even whilst you're operating so that you do not cause further grief to yourself. As in the situation here, significant tibial defects seen on the medial side, reconstructed by using a wedge and a stem. It is important to know what your prosthesis can do for you. It is important to know what depth of wedges are available, because only with that information ready in your hand should you proceed with the procedure. When there is global bone loss, which is not common in primary total knee arthroplasty, but may be the situation in inflammatory arthropathy, extensive reconstruction is required, and constrained device, whether it's a TC3 or a wave one above, is almost inevitable. You need to probably have a hinge type prosthesis available on the shelf. But before you embark upon surgery, I think it is imperative that you should know the cause of why there has been such global bone loss and destruction. Do not embark upon surgery and find out that there is probably an infective focus or a tumor situation where you get completely caught out. I think that extra bit of investigation preoperatively is absolutely mandatory. And this situation is very common in the revision setting. So this is one where there was global bone loss, and you can see the lateral femoral condyle has been completely taken off, significant stretching, probably non-functional, a medial collateral ligament, and I primarily used a hinge. Hopefully, through this, you've seen the entire gamut of what you need to do to try and get out of trouble. But the most important bit is your clinical examination preoperatively, clinical examination after the patient's anesthetized, and then once you expose the patient. Start small, don't make massive exposures, assess the problem as you go along, and then plan. And often, majority of the times, you may need to think on your feet. Thank you very much for your attention. I don't use cement at all because it'll fail. So even if there is a contained defect, I will use all the surrounding bone, crush it up, and put that in, pack it in, leave a trial stem in the hole that I've made, so in the form of a drill, because you don't have a trial stem, and pack the bone around it to reconstruct the area and then put this component in. But I don't believe cement does the job.
But the peripheral defect, little peripheral defect, how much will you accept?
Okay, so there's a trick. That's a great question actually. So the way to assess whether this defect is going to cause you a problem or not, what is I'll change it around. What are we looking for is to try and assess whether that tibial tray is going to be stable or not. How much that defect is going to influence the stability of the tibial tray. So you do your femur, tibia, everything correctly, you put your femoral component in, whether it's a cruciate retaining or sacrificing, it doesn't matter. You put your tibial component in, tibial tray, and you flex and extend the knee. If that defect is going to be significant, it'll wobble the tray. So if it wobbles the tray, you know that defect is significant, and you must do something to it. Otherwise, if you go away, the patient will come back soon, because as they start loading, it will wobble it out. So if it does that, so let's say a 2 or 3 millimeter defect and it's not causing any problem, you can fill it up with cement. I put it to you, if you don't do anything at all, nothing will happen, because essentially, inherently, it's stable. But if you have a 5 millimeter defect, and as you do that test, the tray just wobbles, then you have to do something to it. What you do, I don't prefer cement, because cement is a short-term fix. Whether you put a bone graft with a screw, single screw, 5 millimeters, you could probably translate it, depending on whether your sizes are compatible or not. So the system information becomes very important. Or, like me, even for a 5 millimeter defect, I might sacrifice a little bit of extra bone and put a 5 millimeter step wedge and a stem. You could argue with me and say that is over the top. Fortunately, I have access to it. It looks nice. It's a great operation. It's thrilling bit of mechanics and a mechano trying to fit everything together. Yes, the flip side is I sacrifice 4 or 5 millimeters of bone. But I find it quite difficult that if there's a 5 millimeter defect, to put a single screw in the correct position, perpendicular to the defect plane. Because if I don't put the screw perpendicular to the defect plane, the chance of me getting union also decreases. So swings and roundabouts.
So I would suggest that, because the session is already too late, any further discussions can be made during this. Dr. Sanjeev Gokhale for his talk on uni versus total.
Replacement, which I think well, it's a little difficult, because these are like comparing oranges and apples, because the indications for totally replacement and unicompartmental replacement are totally different. We are talking about two different groups of people. There is one group of people which will require TK and other group which will require unicompartmental. So you cannot exchange one for the other, ideally speaking. Overall pain relief, pain specifically to the knee joint, activities of daily living, and normal knee, the feeling of normal knee, or what is called as a forgotten knee. In every respect, UK scored better. This was, as far as the function was concerned, pain, noise, swelling, stiffness, tears. In every respect, again, UK scored over the total knee replacement. Now this is again Oxford knee score. So as far as Oxford knee score is concerned, this is the result of Oxford knee score at the end of 6 months. As you can see, UKA is doing more excellent than fair, good or below par. So when it comes to comparing with TKR, in these three categories, UK is below TKR, but in the excellent category, we got more UKRs. So if that is so, what are the advantages? Why should people still be doing TKRs? In patients which are indicated for Oxford, in patients which are not indicated for Oxford, obviously you cannot do TKR, so that's just out of question. But sometimes even a patient is good for UKR and surgeon might still go ahead and do TKR, and that happens so often in India. Now why is that so? The reason being, there are three doubts in the minds of most orthopedic surgeons, like when they are confronted with the patient who they think is possible for UKR, then they still want to go ahead with TKR because one, it's a known surgery. TKR surgery as a surgery has been around in India for last 20-35 years. So everybody is comfortable doing TKR. They know TKR in and out. They have been brought up with TKR in their hospital days. So when they are talking about Oxford replacement, they are outside their comfort zone. So they are not very comfortable thinking about Oxford knee replacement. Will I be able to do it? What will be the result? There are so many conflicting reports, whether it's good or bad. People are saying that Oxford knee replacement or fixed bearing replacement as a group, unicompartmental knee replacement has got a worse revision rate. So if that is so, should I be doing UKR? And if I do UKR and if the patient does have a revision, will I be blamed for it? So when we think about more revision rate for UKR as compared for TKR, we need to know the reasons why is the revision rate more. Now it's just not in India, but all over the world, people are talking about increased revision rate almost twice or 3 times as much as UKR, as much as TKR for UKR. Now what are the reasons? The first reason is there are 3 clear reasons for this. One thing is incorrect indication, incorrect selection of the patient. If you do not select your person well and you do Oxford replacement or fixed bearing replacement in a person who should be dealt with by TKR, obviously is going to fail. Now I'll tell you in detail what these things are. Second reason is inexperience of the surgeons, because most of the Indian surgeons are not doing enough number of Oxford knee replacements in order to be conversant with the technique, in order to be skillful in that technique. And number 3 reason is there is lesser threshold for revision. I'll explain these 3 shortly. Number 1. So most of the surgeons are comfortable with just looking at the patient clinically, looking at the weight-bearing X-ray of the patient and deciding, okay, this patient looks like a patient for TKR, or okay, this patient looks a good case for Oxford replacement, without going through the mandatory steps as recommended by Oxford group that valgus stress X-rays should be taken. If you do not take varus and valgus stress X-rays, you should not proceed with selecting a patient. It's just a rule. You just have to accept that. Unless and until you do a varus and valgus stress X-ray, you should not proceed with Oxford replacement. And this has been validated countless number of times. Patient without ACL. Again, if you do not have, I have done without ACL also, but that's a little tricky issue. People have done Oxford replacements without ACL, but I will not go into those cases. Let's stick with the basics. Without ACL, no Oxford. Bone-to-bone contact. It is often felt that, okay, unicompartmental knee replacement can be done in persons who have got less arthritis as compared to TKR. Wrong. Oxford replacement has to be done in severe arthritis when there is bone-to-bone contact on the medial side. It's just that it is restricted to the medial side, but it is of severe category. It is grade 4 when there is denuding of the bone. That is when you should do it, not when it's reduced on the medial side, but when there is complete bone-to-bone contact, only then you should do it. If you do it when there is reduced compartment on the medial side, you will not get a good result. And of course, rheumatoid arthritis, inflammatory chest out. So what are the correct indications? See, that is so what are the correct indications? As you can see in this X-ray, varus stress view, valgus stress view. Varus stress view has to show bone-to-bone contact on the medial side. That is absolutely sine qua non for Oxford replacement. And on the valgus stress X-ray, there should be complete correction of the deformity. It should completely correct. The medial compartment should open, but not too much, because if it opens too much, that means the MCL is lax. It should open just enough to restore it to its normal space, and laterally it should maintain the gap, that is 4 mm gap. It should maintain that 4 mm gap, indicating that lateral compartment cartilage is intact. If it closes, obviously, it's not a good case. Correct indication again, ACL. Looking at ACL in MRI is wrong. Believe me, MRI shows ACL which is intact. You can see ACL in MRI, going from tibia to femur. You open the knee, you put the hook behind the ACL, pull it forward. It has happened to me a few times. You pull the ACL forward and it breaks. It snaps in two pieces. That is when you should change course, go for TKR. So it should be functionally intact, not just anatomically intact. You should not just look in one piece, it should be functionally in one piece. It should work as ACL. Only then you should do UKR.